So once again, the three phases of urinalysis are physical examination, examining the physical properties of urine; chemical examination by way of reagent strips to examine the chemical properties of urine; and finally, microscopic examination. So microscopic examination is we look at the sediments of urine after spinning it in a centrifuge. We observe them with the use of our microscope, and we can see a lot of things under the microscope, including cells like red blood cells, white blood cells. And by now, you should have an idea on what blood cells mean when they're present in urine. And once again, that is called hematuria. Hemat is blood, uria is urine. So hematuria, we can suspect injury or trauma to the urinary system that caused the bleeding. We can suspect the presence of stones or lithiasis, which probably irritated the mucosa and caused some bleeding. And of course, damage to the glomerulus. That's why the blood cells leaked out of the glomerular membrane. Anyway, aside from blood cells, white blood cells, red blood cells, bacteria, we can also see what we call as cast. This is an example of a cast, and this is a very magnified field, and it shows you that it is in the it is in the shape of the renal tubule. So basically, these are proteins that crystallize or solidify in the renal tubules. And a cast can have red blood cells in it. In this case, it's called a red blood cell cast. Or a cast can have white blood cells in it or bacteria in it. Then we will call it the white blood cell cast or the bacterial cast. Anyway, it's not good when you find those casts in your urine, because that means there's something going on in your renal tubules. This is another example of what we can see under the microscope. These are crystals, but these are actually calcium oxalate crystals. They are not necessarily abnormal. In fact, we can see them in urine after you eat a lot of cherries and berries and tomatoes. So we do have normal crystals in our urine, but we also have abnormal crystals. So these are the things that a medical technologist will report so that it can help a doctor come up with a diagnosis. Aside from urinalysis, there are other tests for kidney function. Of course, you have your blood tests, a test for urea and creatinine. Urea and creatinine are nitrogenous waste products, which means they have to be removed in urine, which means they have to be low in the blood. If urea and creatinine and also uric acid are high in the blood, that means the kidneys are not removing them. So there's something wrong with your kidneys because it's not removing these three substances in the blood. We also have ultrasound, and we also have radiography. So this shows you an x-ray of the kidneys. You probably don't see the kidneys because, well, unlike bones, kidneys appear black or gray on x-ray. Only bones appear white on x-ray. So we have a kidney right here, and we could barely see that unless you have a radiologist eye. You should be able to see the a radiologist will be able to see the shadow of the kidney, but we don't see that. But on this side, we can see the pelvis and the calyces. It's the outline of the pelvis and the calyces, and the reason we see that is because this is a stone. So a stone has deposited, or a stone has grown in the calyces and the pelvis, and because this stone is most likely made up of calcium, once we take an x-ray of this patient, it will show on x-ray. Okay, the calculus or the lith, this is a pelvolithiasis, shows an x-ray because the stone is made up of calcium. Big stone. Okay, so let's go back to UTI. So streptococcus is one of the bacteria that can cause UTI. Once we have a bacteria, we will have antibodies. The body will try to fight that by producing antibody. An antigen and antibody complex will be formed. and this complex will start an inflammation. When we had a lecture on inflammation, we talked about increased permeability of the capillaries. So again, there's hematuria. The glomerulus will swell, cells will proliferate in an effort to repair, and renin will be released, which will increase the blood pressure. Now, all of these processes can result to, well, one, full recovery, because after all, inflammation is the beginning of healing, but it can also result to acute renal failure, and for some, it can result to chronic glomerulonephritis, which will result to chronic renal failure. Ultimately, acute renal failure and chronic renal failure will result to death, but majority of acute renal failure will also undergo full recovery. So let's not take UTI for granted, because we don't want renal failure. So here are a few causes of renal failure, both acute and chronic. Hypertension can cause renal failure. Obstruction anywhere in the urinary tract. We showed you hydronephrosis earlier. Nephrotic syndrome, drugs, autoimmune diseases, polycystic kidney. I have a picture of polycystic kidney later. Diabetes. Renal failure is a complication of diabetes. So this conditions, along with other conditions that we will see in the book, can result to renal failure. So what happens when you have renal failure? You don't have an organ anymore that will basically clean your blood or rid your blood of waste. So what we need is something to clean our blood so that we go back to homeostasis. And that procedure is called dialysis. So this is a picture that you can find in your book. I think it's in the older edition, but these are two types of dialysis: hemodialysis and peritoneal dialysis. Basically, these are artificial ways of cleaning the blood, removing waste materials from the blood. In hemodialysis, we create an artificial fistula in the patient's arm before we subject them to hemodialysis. And once we have that fistula, we now have this tube that basically collects urine from the patient's arm, brings it to this hemodialyzer or dialyzing machine, and once blood is already rid of waste, it goes back to the body. So this is like the big artificial kidney. So patients can have their hemodialysis once a week, once a month, twice a month, depending on how many nephrons are still able to perform their function. Of course, the less nephrons you have, the more dialysis sessions you need. Another type of dialysis is peritoneal dialysis. Okay, so we create a hole or a stoma in the patient's abdomen. We introduce a clean, low concentration solution and introduce it into the abdomen. So basically, we bathe the abdominal organs with this fluid. And what happens is this low concentration fluid will attract the high concentration blood feeding the abdominal organs. So if you remember from basic anatomy or biology, we have the transport mechanism known as diffusion, the movement of molecules from a high concentration to a lower concentration. So something like this. This is the blood, and this is the fluid that we are introducing in the abdomen. So this is the blood that needs to be dialyzed because the kidneys are not cleaning it anymore. So this dialysate, because it has low hydrogen, low potassium, low nitrogenous waste, automatically by diffusion, these substances will move towards the dialysate. Okay? The red blood cells will remain in the blood, of course, but anything else that is in excess here will move towards the dialysate. So after the equilibration period, so basically this is the patient waiting for homeostasis to take place, waiting for all the waste to go out of the system into the dialysate, reading, watching TV. This is what happens after equilibration. So now the dialysate is filled with the sodium, the hydrogen, and all the waste. Now we can open the valve and drain the fluid that we initially infused here. We drain that, and now what we have is the dialysate, which is high in waste. So this is like a substitute for the kidneys. Because the body is not able to rid of waste, we introduce a fluid. The fluid will the fluid there and blood, there will be equilibration, and then we drain the solution once it's already passed through the diffusion process. In peritoneal dialysis, one of the complications of this is infection, because you do have an actual opening here. Okay, so the patient can be prone to peritonitis. In hemodialysis, one of the major complications of that is anemia, because you have blood gushing through the tube into the machine, and some of them may get hemolyzed before they even go back to the system. Here is a picture of polycystic kidney that I was telling you about. So polycystic kidney, poly means many, and these are your cysts, and anybody who has polycystic kidney will ultimately suffer from renal failure. So that's a polycystic kidney, and this is a cut section of the same kidney. So there's really no nephrons there. There's really no pyramids and cortex. They're mostly just cyst. Okay. So we have talked about the functions of the kidney when it comes to acid-base balance, maintaining hydrogen and bicarbonate balance. We talked about how the kidney maintains blood pressure, fluid, and electrolyte. Now let's talk about more of the water balance. So water is necessary for many functions, and the normal amount of water in the body is really a lot. It's 2/3 of the body weight. Babies have more water though, that's why they're very prone to dehydration, because the body of the babies have 75% water. There is continuous mixing of body fluids in the from the lungs, the GI, cells with fluid inside, kidneys, and of course blood. So there's always continuous mixing of water. This is water intake every day, 250. Our body always produces 250 ml of water every day, on top of water from our foods and water from our drinks. This is how much we excrete. In feces, 100 ml comes out. Sweating, 200 ml. Breathing, 700 ml. But mostly we remove water through urination. So how does the kidney maintain water balance? Well, basically, if we need to conserve water, the kidney will reabsorb water. But if we have too much water, then the kidneys will basically filter, not reabsorb, and even secrete water and make our urine diluted. So the kidneys are able to dilute and concentrate urine depending on how much water we need or how much water we need to get rid of. Our last slide are other examples of problems associated with aging when it comes to the urinary system. As one ages, there could be urgency, which is the feeling that is necessary to void. Frequency, frequent voiding of urine but in small amounts. Nocturia, need to get up during the night to urinate. Incontinence, loss of control. Urinary retention, which is common in males because of benign prostatic hypertrophy or BPH. So the prostate is sort of squeezing the urethra, hence they're not able to empty the urinary bladder. So these are things that we can all look forward to when we age: urgency, frequency, nocturia, incontinence, and urinary retention. Of course, on top of that, there are also other diseases of the urinary system, such as cancer and